Yes, Mama do.
Good morning, Alex.
Morning. Okay, Dr. Kapaya, over to you, please.
So good morning, everyone, and welcome to yet another very important webinar where we are discussing IPC-WASH for cholera response in the East and Southern African region. My name is Fred Kapaya. I'm going to be your moderator for this webinar today. And so just a warm welcome to all of you for finding time to join. So I'll take you through the housekeeping for this webinar and also how the program is going to run. First and foremost, I'd like to indicate that the purpose of this webinar is to equip participants with the requisite knowledge and tools to conduct cascaded training for healthcare professionals and also facilitate IPC-WASH assessments, mentorship, and supportive supervision in healthcare facilities, including cholera treatment centers and cholera treatment units. So this is a very important webinar, and I urge you to pay particular attention. So before we start, please note that this virtual training adheres to the Code of Conduct to prevent harassment, including sexual harassment, at all our WHO events. So even this one, we actually comply with this. So just want to take you through how we are going to conduct our business today in this webinar. So regarding questions as well as answers. So if you look on your screen, you have a Q&A. You're going to use this feature for questions regarding the topic and presentations. And only questions that are in the Q&A will be answered during the sessions. And you then be able to use the feature, as you can see on the screen, the chat feature, for questions regarding IT or logistics. So anything that regards IT or logistics, you use the chat feature. I want to indicate right from the outset that there is no interpretation in French and Portuguese. So this webinar is in English. Of course, we are going to organize another webinar for the Francophone countries, which will be done in French. Regarding the captions, you can click on the show captions and the caption would appear on the screen, as you can see. And to close the caption, you click hide captions and it will hide the captions, as you can see. Regarding recordings and also the materials, we are saying that this session is being recorded and we take your attendance as consent to be recorded. The session materials, including session recordings, will be shared with the participants in the days following the webinar. As we continue to improve our training programs, we value your feedback. Therefore, a survey will be shared at the end of the session. We highly encourage you to share your thoughts and suggestions. Your input will help us tailor future sessions to better meet your needs and expectations. So let me take you through the agenda for today. So the introductions as well as housekeeping, this is what I'm doing right now. Opening remarks, I'm going to give opening remarks on behalf of Dr. Solomon. And then on IPC preparedness, readiness, and response, we're going to have Ms. Tendai Makamure. Thereafter, we're going to have a presentation on WASH preparedness, readiness, and response by Christopher. And then we're going to have WASH in cholera by Mr. Mbayo Guy. Thereafter, we'll have prevention of cholera transmission, the fecal-oral transmission, which will be given by Dr. Deborah Barasa. Then we will have an opportunity to ask questions and have a discussion. After that, we're going to have IPC-WASH, CTC assessment tool and improvement plans which will be given by Moses. And then we're going to have country best practice presentations. We're going to have sharings from Zambia and Malawi, their best practices. Then we'll have a discussion. And after that, we'll have actually next steps and closure. So ladies and gentlemen, this is how we're going to run the program for today. So allow me to quickly move on to the opening remarks. Like I indicated, I'm giving the opening remarks on behalf of Dr. Solomon, who would have loved to be with us, but because of other equally important engagements, is not with us. So I'm going to read exactly as he wanted to actually put it. So distinguished representatives from member states, esteemed partners, and dedicated stakeholders in infection prevention and control, water, sanitation, and hygiene, a very warm welcome to you all from WHO Eastern and Southern African Region Office, Nairobi, Kenya. It is an honor to address this esteemed gathering as we unite our efforts in combating one of the most persistent and devastating public health threats affecting our Afro region. Today, we are faced with a sobering reality of the critical role of IPC-WASH in cholera preparedness, readiness, and response. From January 1, 2022 to May 26, 2024, the African region has witnessed an alarming cholera situation. A total of 377,425 cases have been reported since 2022, resulting in 6,708 deaths, giving a case fatality ratio of 1.8%. Since the beginning of this year alone, we've seen 91,667 cases and 1,605 deaths, with almost the same case fatality ratio. 18 countries have officially reported cholera or acute watery diarrhea cases, with 4 countries, Comoros, the Democratic Republic of the Congo, Ethiopia, and Zimbabwe, currently in acute crisis. In Eastern Africa sub-region, where there is a reported heavy rains and flooding, we anticipate further cholera outbreaks. These numbers are more than statistics. They represent lives lost and communities devastated. They remind us of the crucial role that IPC-WASH and rapid response mechanisms play in preventing and controlling cholera outbreaks. Effective IPC measures are paramount to curbing the spread of the disease within the healthcare system and the broader community, ensuring the availability of trained HR capacity, guidelines, SOPs, unnecessary IPC supplies such as PPEs and disinfectants are crucial. Furthermore, water, sanitation, and hygiene are foundational to our cholera prevention efforts. Access to clean water, proper sanitation facilities, and the promotion of good hygiene practices are essential to interrupting the transmission of Vibrio cholerae. Investment in infrastructure to provide safe drinking water and adequate sanitation, coupled with robust hygiene education programs, can drastically reduce the incidence of cholera. Our efforts in IPC and WASH are not just about preventing and controlling infections. They are about fostering resilience, and ensuring sustainable development. The success we have achieved thus far in reducing the incidence of cholera and other waterborne diseases are a direct result of the hard work and dedication of everyone in this response. However, as diseases are a direct result of the hard work, as we continue to face new challenges and evolving threats, our resolve must remain steadfast. We must continue to invest in strengthening our IPC and WASH systems, ensuring that they are robust, adaptive, and capable of responding swiftly to outbreaks. This includes improving IPC-WASH capacities, enhancing surveillance, improving infrastructure, and fostering community engagement and education. By doing so, we can not only combat cholera, but also create a solid foundation for addressing other public health emergencies. Today, let us reaffirm our commitment to these essential strategies. Let us leverage our collective expertise, resources, and innovation to build stronger, more resilient health systems. Together, we can achieve our goal of a cholera-free region where every individual has access to safe, proper sanitation and knowledge to protect their health. Thank you for your dedication and continued support. I look forward to our productive discussions and the actionable outcome that will emerge from this important webinar. Together, we are stronger. Together, we can make a difference. Thank you very much. So those are the opening remarks on behalf of Dr. Solomon, who is actually the head of emergency response at the Nairobi Hub, WHO Afro. So, ladies and gentlemen, we'll quickly go to the next presentation, and I'm going to call upon Ms. Tendai Makamure to give us a presentation on IPC preparedness, readiness, and response. Tendai, you can take it up. Thank you.
Thank you very much, Dr. Kapaya. Good morning, colleagues. And I'll be making a presentation on IPC preparedness and response on behalf of the IPC team. I hope you can hear me and see me clearly.
We can see you, we can hear you. Proceed.
Okay, sorry. My apologies. So I will talk about IPC preparedness, readiness, and response. And I think at the end of this, we must all be able to understand the importance of IPC in emergency preparedness and response, and also understand the structure. So IPC-WASH readiness for cholera outbreaks, describe also the key IPC-WASH activities that should be done during cholera outbreaks, and also how we can activate and implement coordinated IPC-WASH responses. So just a brief overview on why infection prevention and control and WASH are important when we talk about cholera. We are saying that IPC is an evidence-based approach which is critical in preventing the spread of pathogens, and also it also protects the health workers, the patients, and the visitors who will be coming to the cholera treatment centers and the healthcare facilities during the cholera outbreaks. IPC is also important by improving quality of care. We are also instilling the confidence in the patients and also in the communities that they can easily access the healthcare facilities without being exposed to infectious pathogens as well. We are saying also IPC is also quite a key intervention in facilitating early identification when we are doing screening and isolating patients, suspected cholera cases, and we are sending them to the CTCs. By reducing also practicing IPC measures, we reduce also the incidence of the transmission of cholera, thereby reducing the number of new cases. By improving the quality of care, we also reduce mortality and morbidity. Noting also that when we have good IPC measures, it means that the patients are the risk of healthcare associated infections, which may prolong their stays in hospital, will be reduced, and therefore we are reducing morbidity and the length of stays in the CTCs and in the healthcare facilities. IPC is also quite an essential component of the international public health security by helping to prevent the spread of diseases beyond borders. It is quite a key component that is important. In this next slide, I want to emphasize the importance of infection prevention and control in emergency preparedness. The role of IPC, as we may have noted, usually becomes illuminated during an outbreak, yet we are supposed to start supporting IPC initiatives in preparedness, and in all these planning processes, IPC is quite critical. When we have done the risk assessment in the country, we have identified the key hazards, we have finalized the risk profile for the countries. As IPC, we should be able to come up with key interventions of how we are going to mitigate the hazards that have been identified. It means that if it's cholera, we need to have the IPC SOPs in place as part of preparedness. We need to have the training materials. We need to have capacity building so that based on the risk calendar, when we are anticipating that cholera is going to come, an outbreak is imminent, we have already adequately trained our people at national and to the lower levels. For the joint external evaluation, the IPC also is a key for IHR core capacities, and the gaps that are identified in the joint external evaluation, they are the ones that are used to develop the national action plans for health security. And these plans are what we are saying they will be supported by. In our national IPC strategic plan, we need to take into incorporation the outbreak component, which is addressing the gaps in the JEEs, the gaps in the risk assessment, highlighting the hazards that we're going to support in our national strategic plan. So in a nutshell, I'm saying that IPC plays a key role in all of these. It's a critical component. And if it's often left out during responses, we will keep having challenges and gaps. Also, as part of preparedness, the routine work that is done in IPC, where we do national assessments to evaluate capacity, work on establishing IPC programs at the national and facility levels, develop guidelines and disseminating them and monitoring their implementation. These are all quite key activities that are supposed to be implemented during preparedness. We should have also components of outbreak plans at national level and also for the national level. We also need to have the routine training programs that are recommended, which are aligned to the minimum requirements, which also include a component on the outbreak, so that as part of preparedness, people are already adequately trained and know how to respond and to support cholera treatment centers before the outbreak happens. We have healthcare-associated infection surveillance, which is routinely going. We also have IPC outbreak response teams who will be integrated as part of the rapid response teams. And we also have routine monitoring and audit of IPC practices so that we are always aware of the gaps and the support that is required in improving the infrastructures at either healthcare facilities or for supporting in CTCs when we are now facing an outbreak. So now we are moving from preparedness to readiness, and we are saying that when now it's readiness, we now have a defined specific threat. And in this case, we are anticipating a cholera outbreak. And what's important is that we should be able to establish and activate and coordinate IPC-WASH response teams. We should be able to update any existing IPC outbreak plans. We should be able to establish or activate the IPC surge capacity implement IPC measures in healthcare facilities, including in CTCs that will be used to support patients. We will also be able to train healthcare workers, disseminate the available IPC guidelines and SOPC, also in collaboration with RCCE and health promotion, implement IPC-WASH measures. We are also able to strengthen the national, subnational level IPC-WASH task force or committees, depending on the context, and also set up committees at the healthcare facility levels, and also establish IPC-WASH at their points of entry. And lastly, have an IPC communication strategy, and this will usually be in collaboration with RCCA. So when we mention on establishing the National IPC-WASH Task Force, we are saying it is critical that we have a task force which has defined terms of reference and also comprises of different expertise. The IPC focal points from Ministry of Health, WHO, and other partners, the WASH focal persons from Ministry of Health and other partners and WHO, and also they should be assisted. We can incorporate key personnel in those teams, such as the logistics and data management people, and even surveillance people. They can be part of the technical working group to support this. And there should be another task force which mirrors the same task force at the national level. At the subnational level, it can also be a small team. So the key responsibilities for the IPC-WASH task force will include at the national level, reviewing the existing IPC-WASH equipment and materials. This is looking at the SOPs to be used, the tools for assessment, the training materials, the supplies for WASH, for IPC that will be required. And it will be also important at the national level that the Ministry of Health endorses the package that is going to be used across for the cholera response at all levels of care, from the community to the facility levels. Another key task for the National Task Force or committee will be to monitor and advise on the quality of IPC capacities in the high-risk areas, and also reinforce practices within the communities on food safety. Also monitoring the risk of infection amongst the health workers and adequately supporting them, and also doing healthcare facility mapping in conjunction with case management and surveillance. Surveillance will usually help us to identify the priority healthcare facilities which require support. The national team also is responsible for partner mapping so that we are able to synergize and harmonize support to the cholera response and avoid duplication of activities on IPC and WASH, and also support with the coordinating community engagement to ensure consistency in messaging at healthcare facilities and also within the communities. There should also be IPC-WASH committees at healthcare facilities, and similarly, they should have terms of reference and also comprise a team of key relevant people. And important to note that at facility level, at facility level, it should include leadership administrators as part of the team, or the pharmacy department, which in most instances is responsible for procurements when it's at facility level, the laboratory people, those who are in waste management. This should just be defined according to each country context and also what is available at the health facility level, environmental health technicians, all of those key important roles, they should be part of that. And their key role will be to support the implementation of IPC and WASH activities in the healthcare facilities. We should be able to, at the national level also, to activate the IPC SAGE capacity. We should constitute IPC personnel who should be part of the rapid response teams and responsible for healthcare facility mentorship and supportive supervision, responsible for supporting with quantification and pre-positioning of IPC supplies and also HR capacity. They should also be responsible for conducting trainings of trainers and cascading the trainings, and also have safe dead burial teams who are trained. All of these teams should be available and trained as well. And it's important to note that there should not be a disjoint on people who normally do IPC work within the healthcare facilities when there is an outbreak. As we said in preparedness, they are already capacitated and they are continuing to receive training on IPC. Therefore, they should be able to support the rapid response teams to build part of the surge capacities. And also they should be responsible for monitoring IPC-WASH capacity and facility and community levels, and also monitoring water quality and conducting water quality monitoring. They should also establish a national stockpile of IPC-WASH supplies and equipment that are required, and ensure that there are cars available for transportation of teams, and also that they are included in the planning process for deployments as part of RRTs. For the communities as well, there are key measures that are required for IPC. We talked about the availability of committees also at the community level. And also we need to have a standard package for the community, which may be guided by the case area targeted interventions approach. And also we need to make sure that there is, we are talking about IPC and hygiene, and I think our colleagues will talk more on WASH, ensure that there is access to safe water and hygiene, including emergency provisions of water treatment during an outbreak, and also reinforcing the availability of hand washing stations in marketplaces, food vending places, and also social gatherings as well. And it will be critical that IPC, the National Committee, at the national sub-levels work hand in glove with the RCC activities on promoting hand hygiene, distribution of supplies, hygiene supplies, and also improving education and awareness. Another critical component is the ensuring of safe and dignified burial practices. We should have a simple list of main recommendations for that will help to support the communities to conduct safe burials under the supervision of the teams from the healthcare facilities who will be leading the process, train the appropriate community members for safe and dignified burials, and also be able to investigate local funerals that will be happening. In the implementation of IPC-WASH measures in healthcare facilities, as we mentioned, we map the facilities that require support. We prioritize where we should deploy the support, and also we conduct the partners mapping at the facility level. Sometimes we have different partners supporting different regions. We need to conduct a 4W matrix on them and coordinate the support in implementing IPC-WASH measures in the priority CTCs and healthcare facilities, and also establish the isolation referral pathway. We also need to ensure that there is IPC-WASH measures being implemented. And one of my colleagues are going to talk about one of the tools that has been piloted in some of the countries to do assessments in CTCs, and also currently in other instances where people are using the GTFCC tool, also quite recommended, where we are saying that the process is the same. When you evaluate a CTC or health facility, you need to come up with a plan, and you need to have actions and responsible people who address those gaps identified, and also supportive supervision and mentoring will be critical to improve and address some of the gaps that would have been identified. And following that, it will also be important to have routine continuous re-evaluations of the CTCs and submitting the data to the next levels, this regional level and to the national level, so that they also identify areas of support and take note of improvements. There's also need for surveillance within healthcare facilities, depending on using the national adopted case definition. We need to be able to rapidly identify and isolate suspected cases, and also have occupational health policies and systems in place for the healthcare workers who will be working in the CTCs and in the healthcare facilities, to make sure that they are adequately protected and they have systems in place that if they are exposed to, let's say, needle pricks, they have the necessary resources to address that. Another key point is on the IPC at the points of entry and control. We also know that, as we have seen in the region, in the East and Southern Africa region, we have had some imported cases in other countries, and it is important that we map the key entry and control points that to target to implement and improve IPC measures. And what will be important, since we are talking of the transmission of people, will be very critical, ensuring the availability of safe and clean water at these points of entries to ensure that people adhere to the recommendations and practice hand washing as well. And also it might be necessary to implement screening, isolation, and have notification systems at the points of entry and points of control. And on the communication, IPC communication strategy, as I mentioned, there's need to collaborate with the RCCE to develop or adapt any existing strategies for cholera so that people have the up-to-date information and the recommended practices. And when we talk of healthcare facilities, we know that there's always new evidence that is coming up, and there will be need to update those practices, the IPC protocols, so that people are aware of that. So I think this will be my last slide. In the long-term interventions for WASH, as I conclude this, it will be also key to note that a comprehensive and multi-sectoral intervention that target hotspots, and it will be important that we focus on sustainable improvements in water supply, sanitation, food safety, and community awareness as well. And our interventions should target cholera hotspots, focusing on IPC and WASH surveillance and reporting, healthcare system strengthening, use of oral cholera vaccine, community engagement, leadership, and coordination. So IPC-WASH is important to ensure that we are protecting the patients, the visitors, and the healthcare workers. And the IPC-WASH pillar should be integrated in the IMS structure as a standalone pillar for the effective coordination of IPC activities. And they should be included in the response plan, and they should have budget allocated. So this is just some of the references that we have used in compiling the presentation, which include the preparedness framework for IPC, the GTFCC, and the core components on IPC. Thank you. Over to you, Dr. Kapaya.
Thank you very much, Tendai, for a very comprehensive presentation. We really appreciate. So before I call upon the next presenter, just want to appeal to everyone that please feel free to ask your questions. We have the Q&A. Please use the Q&A to ask your questions, and the panelists will actually be able to attend to those questions. So far, we haven't seen any question in the Q&A. So that's why that feature is there. Please use that one. So next, we're going to have a presentation from Christoph on WASH preparedness, readiness, and response. For the oral questions, I think we'll give you a chance when we have a discussion. But for now, let's be posting our questions in the Q&A. So Christoph, take it up. Thank you.
Okay, I'm setting up the presentation. Let me know if you can see it well.
Yes, we can see it. You can go ahead.
Hi, everyone. My name is Christophe Valingo. I'm a water sanitation engineer as well as an epidemiologist, supporting the WHO cholera IMST for the global response on cholera. So today I'll be just speaking briefly about the different elements that are important in the cholera response, mostly in the WASH pillar. So just a small, it's not a set of definitions, but at least to understand which phase in a cholera outbreak cycle, I would say, no? So the first phase maybe is when there is absolutely no cholera cases or no risk of cholera and we can see this at district level or at regional level or at national level or even sub-regional level. So then we're maybe in a phase where we want to do cholera prevention activities and cholera preparedness. Then there is a second phase where the risk materialize in a way. Maybe it's closer, it's in the neighboring country or it's a neighboring district, and we want to have everything ready to be responding as soon as we have the first cases arriving. Then there is the early detection. So the aim of the readiness is to be able to respond quickly to the first cases. So the next step would be early response. And then if the outbreak, I would say, continue and we have not been able to contain it right at the beginning, then we need to be able to scale up all the interventions, including the outbreak control, to try to limit this transmission and this propagation of the outbreak. And then there is the last phase where we need to be able to continue the response until the last cases are reported. And there is the evaluation phase, what worked well, what didn't work well, and we go back into the prevention and preparedness phase. So when we all know WASH is an important part of cholera response, but I want to highlight a bit why WASH is that important. So here, I'm sorry because maybe it's a bit small, but I will explain a bit more. So here is a representation of an analysis that have been done of 10 years or 11 years of cholera cases globally in the world, where almost 5 million cases have been reported. And we've looked at the different countries. So each point here is each name is a country. And we've looked at the services. So here is the population, the percentage of the population that have access on the left side to safe water, okay? And here on the x-axis is the percentage of the population that are using safe sanitation services. So this group of countries are all the countries that have good levels of water and sanitation services, good coverage of services, okay? So as you see, in blue is the number of cholera cases. So only one country appertaining to this group have reported cholera cases, and it's Dominican Republic because of the Haiti outbreak, where there were spillovers, of cholera cases from Haiti coming to the Dominican Republic. However, all the others, because they are kind of protected, they are not reporting cholera cases. So 98% of all those cholera cases have been reported in countries that have less than 65% of sanitation coverage and less than 80% of water coverage. So which means this is the key message, if we have good infrastructure, good services in water and sanitation, we have almost no risk of cholera, okay? So, of course, we are not in a lot of countries, we are not in this situation yet, but it would be the ultimate way or goal to control cholera in the long term. So this shows why WASH is so important in cholera. If you don't have the minimum services, then you allow cholera to spread and to affect your population. So looking at the WASH response during a cholera outbreak, what do we want to achieve? So really, I would like to highlight that it's really different what we want to achieve during prevention phase, where we want to increase the services, the level of coverage of WASH services. So this is long-term water, sanitation, and hygiene development work from what we do in cholera response. In cholera response, we want temporarily to try our maximum not only to protect like we would do with the prevention efforts, but also to interrupt transmission. So we know it's a transmissible disease. So one case can lead to several other cases. So this is why we will try to interrupt. So the objective of the WASH response is really to try to reduce the propagation, to reduce the morbidity and subsequently the mortality by limiting transmission. So I would like to say in a cholera response, there are three main type of activities or objectives in our response. No, the first type is the first pillar is to try to reduce mortality. So this is all about providing access to safe care, no, but also raising awareness of the population so that they run to the cholera treatment centers and they are able to be rated. The second is to control interrupt transmission, but often when we are in that objective, we are closer to where cholera cases or deaths are reported. So we are trying to interrupt the transmission around those cholera cases that we can see. But at the same time, we can, because here we're kind of running after the outbreak. No, we are seeing a case and we are chasing the cases. But the last element is a different objective. We are trying to be ahead by protecting the population, by giving them enough water, sanitation services, or advice, awareness, hygiene promotion messages, so that they can protect themselves. So all these three levels, we will find them in the WASH sector cholera response. So regarding reducing mortality and supporting the case management in a way, we will have WASH activities, WASH interventions that are supporting IPC in cholera treatment centers, in CTUs, in ORPs, and it's where the infectious risk is the highest because we are concentrating all the cholera patients that are severely affected in the same place. So they will be vomiting a lot, they will be having a lot of diarrhea. The quantity of Vibrio will be the highest in these areas. So it's really important that we support these interventions to try to limit the propagation of the disease. The second level is trying to control the outbreak, is the WASH targeted intervention around cases. So it's called case area targeted interventions, CATIs, but there are different ways of doing it depending on your capacity as well. And we will go a bit more into details after. And there is the last one, the WASH preventive actions in affected and at-risk communities. It can be also in non-yet affected communities. So this is the same. So if we look a bit deeper into the three levels, so the WASH interventions, the WASH IPC intervention that we do in cholera treatments is really, our objective is really to ensure that health centers, CTC, CTUs, ORPs respect the minimum WASH and IPC requirements. So then the WASH interventions will be really supporting the IPC interventions, making sure we have the right infrastructure, a triage, well-designed structure, that the conditions are fine so that IPC practices can be happening, to have regular assessments of these conditions in the health centers, to have the SOPs ready, to have trained personnel, to have weekly supervision, to have the supply, the logistics of ensuring all this is a huge task to be done. In the supply chain also to be identifying the suppliers, either locally or internationally, and having all this well organized, planified, so that there is no shortages. So this is really the part one in cholera treatment centers. Then the second one is the targeted intervention. So this one requires a very high level of training and preparation and logistic, because each time we have cases that are being reported, we need to go to where they live and have an intervention in the households and in the surrounding household. And I will get a bit more in the details. So for this, to be able to do this, you need to have teams ready on the ground. As soon as the case appears, the team is going. So it needs a lot of preparation, and this is a key area to work on during the preparedness and readiness phase. So just on some justification of this CATI intervention, I don't know if any of you have seen or are aware of all the publication that back up this targeted intervention approach, is because the risk of being infected by cholera is really increased. The closest you are to a cholera case or to where a cholera cases live, the highest risk you have. So in the radius of 50 meters around the house of cases, the risk of being infected for you or your neighbors is up to 36 times higher, okay? And this risk decreases over time. So if you're very close to a patient in the 1 to 3 days after this patient has been infected, the risk is almost 50 times higher. But as soon as times pass, this risk decreases to become exactly the same as the normal population. So which means if we want to do a targeted intervention to limit this highest risk of neighbors and family members, we need to act fast, less than 3 days. So usually we recommend that the intervention should be done in 24 or maximum 48 hours, okay? And it's an intervention that can be distributing water, water treatment product, soap, water containers, or giving also education on how to have infection prevention control measures at home if someone is vomiting, for example. So all the cleaning and disinfection activities. So here I've left a number of references so that if you're interested to know more about this justification, you can go and read. On implementation strategy. So we were talking about case area targeted intervention. So this is what is the most efficient approach. Now, every case, every team, each cases has a team sent to this household and an intervention in this household and around neighbors. However, when the number of cases start to be very high, it becomes complicated. Then we cannot keep the pace of doing this because we would need too much response teams. So we switch to cluster of cases, targeted intervention. So instead of taking one case one by one, we look at where we have group of cases and we send our teams in the interventions in the areas that receive the most cases, okay? Another possibility is to not send teams. If you have reduced funding, for example, you're not sending teams with cars and a lot of materials, but you're giving out education and a kit at the patient or at the caretaker at the cholera treatment center, so that when he comes back home, he has all the information and equipment to be able to reduce the risk. So this is also effective, but knowing that the quickest the response is, the more risk you're reducing and the less secondary cases you will have. This one is not necessarily the best one, because maybe you're giving all this kit to a case and he will go back home maybe 5 days or 4 or 5 days later. So you're not targeting the higher risk period. And so it's not the most efficient intervention. And then when you're not really able to have...
We can just try to wind up, Christophe. I think we're running out of time.
Okay,
in 2
okay.
minutes. Thank
So
you.
the last type of intervention is the blanket one, where you try to distribute to everyone, to protect all the household in affected communities. The last part that I was mentioning is preventive interventions in at-risk and affected communities, where you try to protect them by giving them the right messages, so it's linked with RCCE, and protect them by giving them safe water and sanitation. So it's like chlorination, monitoring water quality, and ensuring behavior change approach. So this is the most classical WASH intervention that we usually do. So just a reminder, based on all what I've said, when we want to implement a WASH response, it takes time to have all this ready. So being a bit ahead with the WASH readiness activities is key. If we want to be able to do this, it's not when the fire starts that you train your firefighters, no. So all this needs to be in place beforehand in the readiness phase. So it involves a lot of coordination, because it implies multiple actors: the health sector, the WASH sector, the water utilities, the local authorities, the communities. So a strong coordination needs to be in place. A lot of logistic, because it's a lot of distribution that needs to be made. A lot of training, because we've seen the rapid response team need to be ready to go. So it's not training, but it's also equipment, cars, and supplies to be able to respond. And all this is only possible to implement if you have an emergency and contingency fund ready. So in the preparedness and readiness phase, make sure to have a minimum envelope, at least, to be able to cope with 1 month's response, so that you're not waiting the funds to come to start the response and you've already lost it. That's all.
So thank you very much, Christopher, for a very engaging, very good presentation. And I've already seen quite a lot of questions, rather demand, asking for the presentation, especially on the CAR-T approach. So thank you very much, Christopher, for that presentation. Colleagues, keep your questions. I've seen a number of you are posting in the chat. I'm just asking the panelists to be checking in the Q&A and responding to those questions. Next, we're going to have a presentation on washing cholera, and this is going to be given by Mr. Mbao. Mr. Mbao, you can take it up and give us a presentation. Thank you.
Good morning, good afternoon. Not sure what time it is where you are. My name is Guy Mbayo. I am the Regional Water Sanitation and Hygiene Advisor at AFRO. Can I have your support to have the presentation, please? Amma?
Marachi, can you pin his presentation, please?
Yeah.
Now, the few slides I will run you through will allow us to talk IPC and WASH at the same time. And I want to thank the two presenters for already laying foundation for what we'll be saying now. Next slide, thank you. This presentation should allow me to let you understand what's the mode of transmission for cholera, to let you understand what are the basic and essential WASH requirements during a cholera emergency, and to kind of understand some element of water quality testing and surveillance during emergency. And then my colleague will come on and explain the IPC standard and transmission-based precautions during a cholera outbreak, and especially linking that to operation within either a CTC or a CTU, and then to let you understand how to do the same work of preventing infection, but within a community. Next slide. Cholera is actually a fecal oral disease. It goes from the excreta of one host to the mouth of the other host boldly. And you have on your on the right hand, what we usually call the F diagram that shows how that excreta or that cholera vibrio goes from a first host to another. And we know it can go either through the water bodies that we have around or with the help of our fingers, eventually also the help of flies that goes around, and the field. We don't live in a bubble, and the field can be contaminated. But it also can go through the food we eat if it's not well protected or undered. Next slide, please. And eventually, all the intervention we do, that's what a law has to interrupt what we call the chain of infection that goes from an infectious agent capitalizing on the existence of a reservoir where the vibrio is, and then using any first port of exit to enter the chain we have shown before, from the mouth to the, no, from the excreta or the anus to the mouth, and sometimes through the body by contact. And then it can enter another host. That is the chain we, with all the activities we do, we try to disrupt, to stop. And what we are saying is, for an infection to spread, all the links need to find a way to circulate, a flow. And breaking any of them will likely help stop the disease. But again, it is by putting in place several barriers that we can succeed to effectively stop or prevent and control the infection to continue progressing. Next. So what are these actions we are in fact putting in place? It is the provision of water in quantity and quality required. It is the containing of the excreta in putting in place the right sanitation that can allow dignity during use, etc. It is by ensuring that people behave adequately and have a good hygiene. It is by ensuring safe management of their food, and then indeed by adhering to standard to infection and prevention and control, and by making use also of vaccination. But again, as we said earlier, there is no silver bullet. You want to make an adequate mix of all those ingredients to succeed to effectively disrupt this chain. Next. Christophe, you said and you demonstrated, you showed how much crucial water and sanitation and hygiene was to a response effort when we have an outbreak of cholera. And yes, indeed, I will not try to explain it anymore. Next slide, please. Now, what I would say is during an outbreak, it is important for you to realize that you don't want to work only as a wash for wash, because here, wash is so crucial to the whole response, and to be the most effective possible, you want to make sure that the wash interventions work in tandem with all the other pillars. We talk about surveillance and reporting. there is an element of surveillance that should be conducted by the WASH group, which is around ensuring water quality throughout the time of the outbreak, on before and after. That means ensuring, putting in place the arrangement for a good water quality monitoring. We need to capitalize, for that matter, on any campaign of oral cholera vaccine to either do the assessment of our infrastructure that is in place. We will see with which tools. We need to make sure that the institutions that are in charge of water sanitation or hygiene are also conveyed around the table whenever we are talking about leadership and coordination of an outbreak. We need to make sure that when we strengthen the health system itself to provide the right care to those affected, we contribute our part by managing adequately the waste that could be generated, by ensuring water quality at those places where the risk of contamination is the highest. For Christophe has told us how, as a strategy, we bring actually all the people with the problem on the same spot. We want to provide the adequate water to those facilities, the adequate sanitation arrangement for disposing of this excreta and all the waste that they generate. And again, all we do require a contribution of those affected and those around those affected. And that's how we want to work hand by hand for all the elements of our interventions with the RCCE group. And that we need it very much whenever we talk about CATI or any other intervention one can think of in terms of WASH during an emergency. Next. Water, it is central to a response. We saw as a bit earlier as it was part of the chain of transmission, and therefore we want to ensure that everybody, preferably, could access clean and safe water to prevent cholera, and that we look at the quality, the quantity, and at all stage of the production of that resource, that water. We want to ensure that are in place good measure for regular testing of all the sources. And whenever we find any source that would be contaminated, we want to ensure it is decontaminated. So what is safe water? By definition, it is a water that is colorless, odorless, accepted by the community that needs to use it, even if we put in whatever chemicals we think necessary to use. But definitely it should be free from any impurities. There should not be any suspended solids, and much more, we don't talk about it much, but yet there should not be even any dissolved heavy metals. And it should indeed free from harmful microorganisms. And we will see that we have equipment and tools that enable us to control all that. Next. During a cholera response, could you click twice, please? We want to use chlorine for all treatments, for the treatment of all type of water we use. During cholera, we don't take chances. Water needs to be safe. We recommend to chlorinate your water. You can use different products, but you want to make sure that you treat your water with as it's required. And then we have some standards that we want to make sure that we adhere to. To treat with chlorine, we want to make sure that the water is clear. And that's where we say it has to be, to have a turbidity that is less than 5 nephelometric NTU. We want to make sure that the chlorination is done during at least 30 minutes with a water that has a pH that range between 6.5 to 8.5 and at an average temperature of 20 degrees Celsius. It could be that where you are, your water has a higher pH or a higher turbidities. There are some activities that we do. Either you adjust the pH by some additional by some addition of chemicals. You can do a pre-treatment if it is heavily turbid. You can sediment, coagulate or flocculate. You can even filter that water before being able to chlorinate it during at least 30 minutes. And wait 30 minutes before use. Next. Here I have put a few equipment that you want to use for the testing of your water. We said water need to be clear. You can see that with the turbidity tube. We said we want to chlorinate the water. You can check that with the turbidimeter, with the pool tester, which is in the middle there. You want to have no contaminant, no bacteriological contaminant into your water. You can run a test, but again, most of the time, as soon as your laboratory has confirmed the presence of cholera, Vibrio cholera, from a stool from any of the cases identified, we assume that all the water is contaminated and therefore it needs to go through a treatment, a chlorination treatment. Next. Next slide, please. Yes. Now here, those are the kind of standards one wants to ensure they are in place at the facilities where you bring most of the cases that you have, the CTC or the CTU. And we are saying we want to make sure that every patient can access at least daily 60 liters. And if there is any person accompanying the patient, it is 15. The quantity of water needs to cover the need or the water demand of at least 3 days to avoid any interruption of supplies. And in terms of quality of drinking water, we said in any case, we want to get water from an improved source, a well, a borehole, etc., or a water from a river that is treated. And then when we talk about treatment, you want to ensure that there is a residual chlorine that would be all the time above 0.5 milligram per liter. The pH, we mentioned it, the turbidity already. And then when we have the water within the facilities, we want to make sure that there are some check that the chlorine residual remain available into that water throughout the use, preferably. That means several checks will enable you to ascertain that. There is a need to contain the excreta that is generated, and therefore we recommend to have in the observation and recovery area at least 20 cubicles or 1 cubicle that can be used by 20 people. And in the inpatient area, we want to have up to 50 people able to use 1 cubicle, because as you know, arrangements are such that the cases do not even move from their bed. We recover the excretas. We need showers as well, n'est-ce pas? Therefore, we recommend to have at least 1 for 50 people. And much more important, we want to take and analyze the categories of people that we are servicing and make sure that the equipment we provide are tailored to their needs. If you have people that are physically challenged, you need to make sure that your toilets are built accordingly, etc. Next slide, please.
So just to indicate that you are remaining with 1 minute, sir. Thank you.
Wonderful. I have covered all this. There is a need to adequately manage the excreta and the environment at large. You need to make adequate drainages around the area that is affected, and you want to keep clean the whole environment in any case. Next slide. And I will be landing soon. Waste management. Whenever we have cholera, all that is generated there is considered potentially infectious. Therefore, it's treated the same way. Unlike in communities where we are doing development, we consider that only 20 to 25% of the waste generated is actually infectious. Here, we treat everything we generate, preferably within the facility, and we move no waste outside of the facility. The containers can be cleaned using chlorine solution at 0.2, and the waste area should be marked and fenced to prevent any unauthorized entry. Next. We have different type of product of chlorine derived product that we use for chlorination. According to the percentage of chlorine, active chlorine, we can make different type of dosages. You want to retain that we have three, one at 0.5, one at 0.2%, and one at 2% that are used differently according to the need, either to clean surfaces or to wash hands if we cannot avail water and soap, and then to also disinfect bed sheets, etc. Next. Food safety is one of the important pathways of transmission if it's not adequately handled. And we are saying that we want to keep clean our food, to separate raw and cooked food, to cook thoroughly whatever food we want to eat during an outbreak. We need also to recommend to keep foods at safe temperatures, to use safe water and raw materials whenever required, to clean our raw materials with safe water. We want to cover the food, all the key precautions that are needed. Eating the food with an H, heating the food at least at 70 degrees before eating it, and following strictly all the hygiene guidelines in terms of food handling. Next. And that will be my last. Now, to assess the infrastructure, we recommend to use, according to the type of infrastructure, the sanitary inspections for templates, and we have recently developed new ones that have taken into account various parameters, among which climate change, among which gender, and also inclusion according to different type of vulnerabilities that people have. And you have the link, you received this presentation, I guess. You would be able to go see different type of templates that we have to inspect your infrastructure according to its nature, as you want to make them functioning properly. That will be it for me, and I pass the hand. Thank you, Dr. Fried.
Thank you very much, Mr. Mbayo. Very, very engaging, very good presentation. I'm hoping that everyone is following. I've seen very interesting questions in the Q&A, and also thank you to the panelists. They're actually responding to those questions. Amarachi, we can stop sharing so we can go to the next. Please keep on the questions that you have. Our next presentation is going to be given by Dr. Deborah Barasa, and this is going to be on prevention of cholera transmission, the fecal-oral transmission. Dr. Deborah, you can take it up.
Okay. Thank you, colleagues. I hope you can see my slides.
Yes, you can put it in slideshow. Yeah.
Yes. So I will take it up from GIM Bio and also from the colleagues that have really covered exhaustively about preparedness, readiness, and response. That is Christophe and Tendai. And we'll move to infection prevention and control. This is a slide that we commonly share, and I think also GIMBio has also talked about it. So for the chain of the chain of infection, how do we break it as IPC? And so Guy talked about the 5 Fs, and also we know for the susceptible host, we have vaccination using the OCV, but how does IPC prevent infection within the facility? So for all patients who have cholera, as we all know, is that they are treated in the CTC or CTU setting, and this is through the cohort isolation. What it does is that it reduces the risk of transmission to the general population. Our case management colleagues will talk about accessibility for treatment, but also for IPC, when we cohort them together, we also prevent the amplification of disease within the facility as well as in community. And so that is why it is important for us to cohort these cases. Again, it's important that we treat each individual case uniquely as an infectious risk as we handle them. And again, this is where IPC comes in. So IPC acts as a reservoir and prevents the reservoir aspect of the chain of infection as well as the mode of transmission. So how do we do that? The reservoir. We are cohorting cases. And so by cohorting them, then we are containing the infection. Equally, we have practices like cleaning and disinfection, and this reduces the reservoirs as well as the infectious agents. So the cleaning of utensils, the environment, the linen, and so on. Hand hygiene, again, is critical, and we can see it also breaks the links in various areas, and also the use of PPEs, which breaks the link of mode of transmission as well as the port of exit. And so IPC becomes critical. Christophe talked about the CTC being an high risk and an area of high transmissibility of infection. And so we really need to work to see how we can improve infection prevention and control practices in the CTC, even as we look at the community as well. So we normally talk about standard precautions, and this is really the heartbeat, the core of IPC. These are the basic level of IPC precautions to all patients at all times, regardless whether you are suspected or confirmed status, whether we are dealing with the maternity or the routine services, surgical services, or whether we are dealing with outbreaks such as Ebola, COVID-19, cholera, among others. So these are the basic IPC in each healthcare facility. And you as IPC focal points, WASH focal points, we need to ensure that they are all there. We are not just looking at the transmission, that now we are dealing with cholera, so it's contact precaution alone. No, we need to have the basic or the bare minimum, which is the standard precaution, even before we look into the transmission-based precaution. And then risk assessment, which is a critical activity. For each activity that you're conducting as a health worker, you need to look at the risk. You need to assess the risk. And then from there, you take the necessary precautions so that you don't infect yourself. So these are the elements of standard precaution. There's risk assessment, hand hygiene, respiratory hygiene, patient placement, PPE, aseptic technique, safe injections, environmental cleaning, linen, handling of laundry and linen, waste management, and discontamination and reprocessing of reusable patient care items and equipments. And I believe you'll all agree with me that within the facility, we see multiple cases. I remember in one of the countries, we even had COVID outbreaks while we have the cholera outbreak. So we still had to look at the respiratory hygiene. Again, we also need to fix lines for patients who have severe dehydration, etc. So we cannot just treat this is cholera, and so it's contact precaution. We are still in a facility setting, and so everything really has to blend in terms of ensuring that the standard precautions, and then we complement with additional. So these are the bare minimum When you're assessing the facilities, when you're looking at the supplies, HR capacity, among others, we need to have this ready. And so the transmission-based precautions are really for the disease at hand. So now we are dealing with cholera, and so those are the contact precautions. For cholera, it's a contact precaution. So here we look at the isolation. We isolate them in the CTC, the CTUs, etc. And then we need to have the signages, the appropriate signages that we need to have for this. So what are the PPEs that the health workers need to use when they're entering the room, etc., etc. We need to have provide PPEs, have dedicated materials and equipments for the cases, and also look at the transport and communication system within the facility. Say, for instance, a patient needs additional management for their case. So as you can see, the standard precaution is really the core. Whatever facility we are dealing with, we need to advocate for that. And then transmission-based precautions are really an addition to the standard-based precaution for the disease at hand. And what we are saying is the multimodal approach, whether it's hand hygiene, whether it's injection safety, waste management, or cleaning and disinfection. We need to build it. We need to have a system in place. For instance, we need to have water, disinfectants, among others. We need to teach it, routinely inform people, the health workers, and train them routinely, yeah? Because at this time, we're recruiting new health workers, community-based volunteers, and they may not be informed about IPC. So teaching is critical, and checking it. One of our colleagues will talk about, that is Moses, will talk about routine assessment to look at the IPC-WASH capacity within a facility and selling it. At times we find there are no reminders, no posters within the CTC. It is critical that we have all these posters reminding them on how to conduct cleaning and disinfection, how to mix their chlorine, hand hygiene, among others. And again, we need to have a culture of change. So hand hygiene must be performed we talk about the 5 moments of hand hygiene. And what hand hygiene does, it ensures that there's no patient there's no contamination from one patient to the other, and even the environment, we're not contaminating the environment, yeah, and as well as we are not transmitting infection to patients, to the staff, and even the community at large. And these are just the 5 moments of hand hygiene. I think we are all familiar with them, but again, we need to have posters. We need to remind each other before touching, before cleaning or aseptic procedure, after bodily fluid exposure, after touching a patient or a patient's surrounding. Respiratory hygiene, again, I believe some of you are telling themselves, this is cholera, why are we talking about this? And as we said, we need to have, we need to look at a facility as a whole as IPC professionals, because these are cases that we may see. You know, diseases don't read books. One can have co-infections, and also within the facility, we can have cases of respiratory illnesses and among others. So let us ensure that we are also encouraging respiratory hygiene. Risk assessment, really, really critical. At times we ask yourselves, where are we wearing this kind of boots? Where are we wearing this kind of things? You yourself as a health worker, you need to assess the risk. If you find that the risk of spillage of bodily fluids, it is a risk to you, then you wear the appropriate PPEs. You protect yourself. If there's a risk of splashing, yeah, you protect yourself. So this risk assessment, I can say that is the critical aspect that we need to look at, even as we are addressing or taking care of our patients in whatever facility we are dealing with. And for PPEs, for cholera, per se is a contact precaution, as the IPC transmission-based precaution for PPEs, but you may need additional PPEs. Say, for instance, in splashes and sprays of body fluids, then you may need masks and eye protection. Again, we need to emphasize hand hygiene. At times we forget that. We need to perform hand hygiene before putting on any PPEs, and we need to put on fluid-resistant gowns or apron if we are thinking that we may contaminate our uniforms or our clothes within the CTC. And upon removing our PPEs, we need to wash our hands again. Okay, and perform the what we are talking about, the 5 moments of hand hygiene. Okay, so for patient care, I mean, again, for fluid exposure, what we've said, again, hand hygiene is critical, then putting on gloves and aprons in case we are anticipating contamination of our clothes. And this may include when we are patient environment is soiled with stool or vomiters, contact of mucous membrane or non-intact skin when we're inserting IV lines, and when we are conducting cleaning and disinfection of small volumes of soiling. But when you are anticipating risks of splashes or sprays of the body or chemicals, then apart from the gowns or aprons and examination gloves, you may consider wearing face masks and medical masks, face shields and medical masks. This includes handling buckets containing diarrheal or vomiters output, or bathing or dressing patients with diarrhea, cleaning and disinfection of large volumes of soiling, and changing, handling, or laundry which are heavily soiled. Again, hand hygiene needs to be performed fast before accessing or putting on PPEs, and gloves are put on last and taken off fast. So do not use gloves for more than one patient, and always assess the risk. At times we find that even when we are taking blood pressures, when we are writing the vitals, people are wearing gloves. No. You need to assess the risk. You may actually use gloves and become a propagator of infection within a facility. So let us use our gloves rationally. And after removing, we should wash our hands, and we should always know that the gloves do not replace hand hygiene. We need to routinely wash our hands to protect ourselves. I always like talking or advocating about safe injection practices. We are as health workers will be called upon always in a facility to fix a line or to give IV or IM injections. So we cannot separate this and say this is diarrhea, this is a contact precaution alone. We need to talk about safe injection practices. And so let us be advocates of this. So we need a clean workspace to avoid contamination, hand hygiene, as we had talked about, and sterile injection equipments. They reuse prevention features or sharp injury protections. Those features are really critical, and using sterile injection equipments is also important, so that we are not using damaged equipments or punctured equipments. We need to ensure that for the safety of ourselves and of the patients, that we're using the right equipments. Again, sterile vial of medication and diluent, we prefer single dose to multi-dose vials, but if you're using multi-dose, then you need to check the time, the type, volume, as we routinely do within the facility. Again, skin cleaning with 60 to 70% alcohol-based hand rub. Let's not forget that when we are fixing the lines, and appropriate collection of sharps, so to prevent infection, as well as appropriate waste management. So again, in the facility, we even observe that the floor might be damp, and we're putting our sharp boxes down there, and the water seeps in, and we find that the contaminated blood is coming to the environment. So let us see, where are we placing our sharp boxes? Where are we ensuring that we are discarding them appropriately? And that is our work as IPC. And how about cleaning? Okay, cleaning and disinfection, from the cleanest to the dirtiest. We need to clean the patient equipment. At times we forget. We need to clean, ensure that the cleaning supplies remain in the isolation area. Clean from high to low areas, from outer to inner, and the isolation area is the last to clean. We're not cleaning the pharmacy, the isolation, then you move to pharmacy or records. You finish with the isolation area, which is the dirtiest area, really. Yes, among others. And spraying of disinfectants, not recommended. As you remember, during COVID, aerosolization, at times you find the mixing of the different disinfectants, which can lead to chemical pneumonitis. So we don't encourage that as well. And so we need to in order to achieve disinfection, as we said, we first of all clean the surfaces. We must clean first and then disinfect. Why? Because by physically removing and breaking the organisms, what we are doing, we are reducing the load of the organisms. And also remember, disinfectants, they lose their efficacy when the place is heavily soiled. So by manually removing or breaking apart the organisms through cleaning, and then we follow up with disinfection. So what we are seeing is people are disinfecting without cleaning, and that is really, when you look at it and when you conduct swabbing, you observe that the microorganisms are still present. So let us remember and emphasize the importance of cleaning and then disinfecting. So we have posters that we will be sharing with you, such as for the chlorine mixing, as well as the process of how to make the different chlorine solutions so that you can use them within your facility, as well as how to conduct cleaning and disinfection. Equally, the cleaning of bodily splashes or fluids, heavy fluids within the environment, we need to ensure that we are using the right or appropriate concentration of chlorine as we conduct that. Again, for the towels, buckets, and mops, same thing. We clean and then we disinfect, then we rinse and allow to dry. So even for the laundry, the buckets, the same thing applies, that we first clean, then we rinse, and then we clean, we rinse, and we first clean, and then we soak in 0.2% for the heavily soiled, or 0.05 for the unsoiled linen, then we rinse, and then now we can hang for drying, whether it is PPEs or whatever equipments we are cleaning within the facility. Again, waste management, we need to look into this, ensuring that they are 3/4 full, they're not heavily, so that we're not contaminating ourselves. We avoid to use staples or metal coils, and instead using the swan neck sealing method, and also ensure the transportation is looked or adhered into, so that even our waste handlers are not infected, or they are not exposed to infection. Okay, the cleaning of buckets is the same thing. What we talk about, we rinse, we wash with the soap and water, we rinse, then we put 0.2% chlorine, observe the contact time again, and then we put the buckets to drip. And after that, we put 1 centimeter of 2% chlorine, and then the patients can use. But all wastewater must be collected in a grease trap and then infiltrated via a soak away piece, adhering to the WASH standards. And for home management, your community-based volunteers will come to you and ask you, how do we handle, say a patient has vomited at home or has had an episode of diarrhea, and so we need to talk to them about cleaning and disinfection of the various equipments, and also hand hygiene, and the various IPC precautions that we have talked about within the home setting. So that is it from me. Over to you, Doc.
Thank you very much, Deborah, for again another very good presentation. So colleagues, ladies and gentlemen, we've had about 4 presentations, and now it's chance for us to have a short discussion over the presentations that have been made. So the first one was on IPC preparedness, readiness, and response by Tendai. Then we had WASH preparedness, readiness, and response by Christoph. Then WASH in cholera, and then prevention of cholera transmission, fecal-oral. So these are the presentations, and I've already seen quite a lot of discussion that has been going on in the Q&A, and answers have been provided. So now we give a chance to a few of the colleagues that have burning questions. Please indicate by raising your hand so that we can give you a chance to ask. Feel free to ask, please. Anyone?
Yes, there's a hand by Marco Nsamba. Z.
Okay. Marco, you can go ahead.
Okay. Yeah, thank you, colleagues. Do you hear me?
Yes, yes, we can hear you.
Right. My name is Marco Msambazi. I'm from Zanzibar, UNICEF office. I'm a WASH IPC focal person here, and colleagues here also with me from Ministry of Health. We are trying to argue one issue of disinfecting materials before cleaning. It has been a practice. Most of people, they think that they should reduce the infection in the infection in terms of risk. If it is vomiters, before they remove it, of course, that has been like a practice. If it's a cloth, for instance, soiled the cloth, they would tend to disinfect it first before washing, which should have been maybe washing first and then disinfect. What is really your comment on that? It seems like it's a burning issue. I'm having a person here from Ministry of Health. Luckily, he's a practitioner, and they've been disinfecting because of the fear of having infection. Starting dealing with the contaminants before infecting. Can I have your comments, please? Thank you.
Thank you very much. So you keep that question, and I think very important question. And it's not the first time there have been questions, and I think there have been some guidelines that have indicated that in certain settings. The next is Marcellus. Marcellus, you can go ahead and ask your question. You are muted. Please go ahead.
Good morning, colleague. Can you hear me?
Yes, we can.
All right. Good morning. My name is Yves Marcellus. I work for WHO in Madagascar country office as operational support and logistic. Thanks a lot for the great presentation and yeah, like the update. I have a couple of questions, but first of all, I joined the session a little bit late, so my question probably was addressed in the first part of the webinar, so I'm not sure, but I have a question regarding like the layout of CTC and CTUs. I know there've been a couple of updates addressing that. So like, yeah, if we keep like the different zone, like high risk and low risk and stuff like that. So like therefore we can see like how like the different changes or update have been addressed in the CTCs and CTUs. And also, I have a question regarding the surveillance of water at the community level. So yeah, like practically, I wonder how that have been done, and if there's like couple of kits that have been developed, at HQ or regional level to help countries to yeah, like addressing water surveillance during outbreak responses. And I think, yeah, like that's it for now. Thanks a lot.
Thank you very much, Marcellus. Lastly, I saw, okay, so there's Medson. I saw Innocent raising his hand and dropping, but let's go to Medson. Please, presenters, make sure that you keep those questions so that we can respond to them. So Medson, go ahead, please. Madison, if you are speaking, you are muted. Can you unmute your mic? So Madison, we can't hear you because your mic is muted. Quickly, okay, Madison, quickly, because of time, sir.
Yeah, just a short one. I just wanted us to talk more on maybe allowing guardians in CTCs because it has been also a burning issue in mostly African countries. I'm speaking from Malawi again. So maybe if you can have some highlights on that again.
I presume it's guardians or caregivers in the CTC. Is that the question?
Yes.
Lastly, because of time, we'll give chance to Felix Buleke. Felix, can you proceed with your question? Your mic is muted. Unmute your mic.
Good morning. This is Felix from Zambia. It's just a question on the strategies that we can put in place to encourage The officers that are working in cholera centers or isolation centers, we have noted in the recent past that most of our workers, they tend to have fear, to contract the disease. As a result, they end up not putting much to save the patients. What strategies can we use to ensure that we raise confidence in the workforce as they handle this deadly diseases? Thank you.
Okay, so thank you very much. So now I'm going to ask the presenters to respond to the questions. So the first question was on the issue guidance on the disinfection, the cleaning, what's the procedure, what do you start with? Then I think the next question was on the layout of the CTU. I think that came through as well as very key. Then I think the issue, I think the others I may have forgotten, but I think presenters, you got the questions. So please proceed. Deborah, Tendai, Christopher, and Bayo. Maybe we can start with Deborah on the disinfection.
Yes, and I think I would also want Soro to also complement, because I think this is one of the favorite questions that we tackle very frequently in IPC, what to start with, cleaning or disinfection. And basically what we say about cleaning is the physical removal and breaking apart, yeah, of the soil, the microorganisms, yeah. And what we know about disinfectants is that they lose their efficacy when they're exposed to organics, when they're exposed to soil or any dirt. So when you are disinfecting, you're just killing the top layer, but beneath there are other microorganisms that you will not target, yeah. And so by manually removing, you're actually reducing on the heaviness of the microorganisms. And once now you disinfect, then observing the contact time, you're able to actually further reduce the level of microorganism within the surface. So cleaning is to manually remove the heavy soil, and then now disinfecting is now to further reduce on the content of the microorganisms. So that is the ideal. When you're just disinfecting alone, you are just psychologically treating yourself, but you are not actually, it's not scientifically proven. But since Soro is here, I would wish that he also comments about that.
Soro, you can comment.
Yes, thank you so much. I want to thank everyone here, first of all, Fred, everybody for organizing this. My name is Soro Lasina from HQ, IPC. So regarding the question from Marco, this is a very common question, as said Deborah. But in the IPC, we don't disinfect something that is not clean. It's like you are wasting your time or you are wasting your disinfectant. So we only disinfect something which is clean. So no matter the object, whether it's equipment, whether it's the floor, whether it's any instrument that is dirty, the cleaning is the first thing. You clean to remove, as Deborah said, the organism physically. After that, when you think that it is clean, there's no any other visible salt on it, you go now to the disinfection. So the cleaning includes two. You can even use water to remove before you do the disinfection. You can also clean with soap and water before applying any disinfectant that you think is relevant for that material. So there's no doubt on it. The step is cleaning first. After that, you do your disinfection. Don't take your material just with the organics matter to soak it in the disinfectant. It's not working. Yeah, it's not working anymore. So cleaning, disinfection. Thank you and over.
Thank you very much, Soro, for that. I will ask Professor Bola. Professor Bola, you can go ahead and also contribute.
Okay, thanks everyone. Thanks for beautiful presentations. And I'm just going to add on to what Soro and Deborah have said. And this is really just to let healthcare workers know that that is why we talk about the appropriate use of personal protective equipment. A lot of them want to disinfect before cleaning because they feel they are at risk. And that is why we insist that even cleaners need to use appropriate PPE. So if people are using the appropriate PPE, they can afford to do the cleaning before the disinfection. So one of the things about the training is to train people on how to appropriately put on PPE so that they can do the washing with soap and water and then rinse with water before they now do the disinfection. And this also applies to the spraying that is generally being done. Many people feel that when you spray the environment, you have disinfected it without even cleaning the environment. So it doesn't only apply to equipment or instruments, it also applies to even the environment. It has to be cleaned before disinfection. Thanks, and over.
Thank you, Prof. Thank you very much for that. And I'm sure it is well answered and clear. If you have any further questions, please do not hesitate. You can put it even in the Q&A. The next question was on the layout of the CTC-CTU. I will ask Mbayo, I'll ask Mamadou, and I think Alex to comment. Mamadou, would you want to comment? The layout of the CTC-CTU.
Let me start.
Okay, go ahead, please.
Good morning, everyone. My name is Alex Freeman. I work in the Nairobi Hub as a health logistics officer. So in regards to the CTC layout, I think most of the participants here are quite aware of the GFTCC, which is quite compact with a lot of information, including the CTC layout. And the cholera guidelines also have the CTC layout. However, there is a new technical working group that is being formed at HQ level with technical experts, which together are reviewing the CTC layout from lessons learned from different countries and also from COVID to EVD. So as of today, the layout in the GFTCC is covering almost all areas of the implementation. And if we talk about the layout, what are the zones in the layout that we are looking at? In the CTC, you have basically 3 major areas in your CTC. One, you have your green zone where your staff and your warehouse, your pharmacy, and everything is. And within the red zone is also demarcated. You have your recovery area, you have your screening area, you have your hospitalization, and then you have your morgue. So the layout have not changed. Those are the key areas that you need to map when you plan to set up your CTC. How many bed CTC do you want to set up? How many categorization you want to have? Male, how many bed? Female, how many bed? In the hospitalization and the point of recovery and for discharge. So in short, the GFTCC is still valid and validated, but however, as soon as the technical working group finishes and then come out with the final layout, it will be updated in the GFTCC. The major discussion actually on the layout is more on the setting up of the ORP centers, the oral rehydration centers, which there's been a discussion around it. How should it be? Should it only be under the tree? Should it be improved a little bit to complement some of the CTUs areas where they are quite far from transferring patients? So this is what I can say about that for now. So you look at the 4 categories areas, you need to have your green zone, you need to have your recovery area, you need to have your hospitalization, and on top of that, your waste management area, which are all part of the red zone and incorporated within your hospitalization. So probably I'll hand over to Mamadou, any other colleague. And
Mamadou, would you want to comment?
Okay, thank you very much, Alex. I think you have been explaining it very clearly. Just to mention that this demarcation is very, very important, because in terms of IPC, it helps even to reduce the risk of contamination. You know, as he said, the red zone, mainly the hospitalization is the most area where we have a high risk of contamination. That's why it will help even to limit the staff movement between different areas. I want also to specify that to have some kind of setting in terms of IPC equipment, chlorine supply, water supply in each area where it will really help to limit the movement in different areas. I want also to jump to answer a quick question regarding the answer from Eva from Madagascar. I was asking about if there is some kind of kit can help to do the water quality monitoring. Yes, even yesterday we was discussing with Alex to put this one in place. We already identify a standard kit with a minimum items can help to do monitoring, water quality monitoring by even volunteer. You don't need to be qualified to do that. It will be composed by only 3 items: your tubidimeter, your pool tester, and also a small electronic equipment to do your pH and so on. This one, it will be available soon, in our stock countries. We will maybe share it to countries if they're in need. They can also request. Over to you.
Thank you very much, Mamadou. Thank you, Alex, for those. So quickly, Tendai and Tendai.
Kapaya.
Yes.
Just a quick one. I think Mamadou have touched a point, but I want to clarify which normally happens in the field, as Eve has asked the question. Water quality monitoring and surveillance. Yes, there is a clear defined parameters that we need to check for. We are not doing water safety. We are doing water quality monitoring in regards to cholera outbreak. And we are in the middle of the emergency. So if specifically in the community, the response action is very straightforward and very limited. What do we want to ensure? Point of use chlorination. We want to make sure that there is active chlorine at the point of use. What do we need to measure that? You need your pool tester. You need your reagent, which is the DPD1, to be able to ensure that there is a free residual chlorine in the water as the first point of action. So if we are doing community water quality surveillance, I see many people, yes, we need to do the comprehensive analysis with different parameters, including E. coli and things, but for community engagement, that we need to first priority to attack is the point of view. So we need to segregate where we need to do a comprehensive analysis, but the first priority is to make sure that every household, every point of use for water, specifically for drinking, have chlorine. So we should not mix the two, spending a lot of energy specifically on doing bacteriological contamination testing, which we will only have the results after 24 hours. As much as, yes, it is very important and good, but our key focus should be checking for free residual chlorine, check for the turbidity, as Guy has mentioned, because chlorine is not active if the water is turbid. So those are the two basic, if you want to do a vast water quality in the community, those are the two basic kits we should bear our focus on. Then we go to the actual kit, which needs the experts that need to be able to do for checking for arsenic, the pathological contamination, and so on and so forth, which have a series of parameters that we need to check for, to use those data to advocate for improvement of the water system to avoid hazards. Thank you.
Thank you very much, Alex, and really very good discussions. So just a quick one on the issue of the guardians that was asked. So basically, in an ideal setting where you have a very well-performing CTC-CTU with all the services there, we don't really encourage having people or guardians there. But of course, there are certain situations, especially children, and also there could be very sick people that you may want guardians to be there to help. But what is important is adherence to the IPC measures, IPC standards in the CTC. So we don't actually allow, that's why we have a fence around a CTC, a CTU, because we don't want people to come in, because they're the same people that will take the infection to the community. So where we have a very good system, we don't actually want to have even the bedsiders to the patients. We want to manage them ourselves. And then afterwards, that's when we release them to ensure that they don't transmit. And this also goes to issues of bringing food from home, bringing food to the CTC. That in itself also is a very high risk when it comes to IPC. So I thought I just mentioned that. Quickly, we are running out of time. I'm going to ask my brother Moses to proceed and give us a presentation. Moses, can you quickly give us a presentation on the IPC assessment? But I want to indicate here that so what is going to present is something that we're supposed to be using, but it is being looked at HQ and being validated. But this is the work that we've been working on as Afro. So Moses, please go ahead and share your presentation. Thank you.
Yeah, good morning, colleagues. Good morning, our participants. Deborah, can you please share your screen? Because the presentation is in continuations of what you were already presenting.
Deborah, could you share the presentation so that Moses can pick it up from there?
Okay, so as let me also thank our previous presenters for setting the basis for this presentation. I can recall that all of the presenters made mentions of the importance of assessments in terms of IPC and WASH capacities in healthcare facilities, CTCs or CTUs doing cholera outbreak response. So it is important for us to evaluate the CTC or CTUs to help us to identify gaps in action that should be implemented in order to reduce the risk of infection transmissions and also to ensure appropriate access to treatment. Next slide, please. So as Dr. Kapaya said, the CTC assessment tools that he made mention of is still a work in progress, but whatever tool that has been used, it is also important for us to be able to understand that it is important for us to evaluate the capacity of our CTC, because if we cannot measure the IPC or WASH capacity in the CTCs or CTCUs, it can be difficult for us to improve actions that are needed to promote patient safety. So this is just the objectives of this presentation. It could be a demonstrations of understanding on the use of facility or CTC assessments in order to evaluate the capacity which we already made mention of. Then to be able to also identify the best practices, what are those things that people are doing well that can be replicated in other settings? What are the gaps? What are the areas that need improvement, or what are the opportunities for improvement, and what action can be implemented to ensure appropriate access to treatment? Then this should inform the development of CTC or CTU improvement plan based on the assessment results. So CTC assessment is also critical because it helps us to monitor and track progress implementations of facility-specific improvement plan. This is very critical. Next slide, please. So the evaluators or the assessors doing CTC assessment have some critical role to play. And one of them is to be able to identify priority gaps and most urgent actions. All of the actions at the facility, if you do an assessment, it is important to be able to categorize them based on a potential risk. What are the ones that I most urgent, and what are those ones that you can do later? The assessor should also have the capacity to develop an improvement plan. Developing an improvement plan is very critical because it helps you to identify the gaps. And this improvement plan should be jointly developed also with the facility management teams and also the IPC focal person, because these are the owners, or these are people who will also be following up with those actions that have been developed to address the gap that been identified. It is also important for the assessor to know how to use an open-ended, respectful, or engaging, non-judgmental communication to demonstrate that is very important. Because in the assessment, we are not there to judge, we are not there to really criticize, and it should be open, and it should be flexible, and it should be a kind of two-way of communication between the assessor and also those that are being assessed, or the facility that is being assessed. Next slide, please. So why do we do CTC assessment? We already talked about this. We say that it is an important step because especially in the planning and implementations of IPC activities, data is important. Data is important because it helps us to know exactly what we are doing. So when we do our CTC assessments, it enables us to know what are the best performing CTCs, what are the poor performing CTCs, and what are the actions that are needed. So it is very important for us to do that. That can help us to reduce the risk of transmission. That's the overall goal. We want to reduce the risk of transmissions of cholera and other healthcare associated infections in the CTCs or CTCU, that is from patient to patients or from patients to healthcare worker. When it should be done, when a suspected or confirmed case of cholera has been identified or isolated in the CTC. By whom? It's not just anybody. The person who is doing the assessment should be somebody who has been orientated or who has the competence to do IPC and WASH assessment. Next slide, please. Next slide, please. Good. So we already talked about this. Then it assesses the implementations of 6 key indicators. Then we'll talk about those. We'll just give a summary of those indicators, those parameters that should be assessed. And the frequency of follow-up and formative supervision will be defined according to the results. So you have the result. After the result, you'll be able to identify those that can be addressed in 4 to 48 hours, that is 1 to 2 days. Then priority as soon as available or possible. Then you should be also be able to demonstrate what you call a good practice. So you plan, resources, and implement. That's one of the good practices that we talked about already. You should be able, after the assessment, to be able to have to mobilize resources and to implement the improvement plan have been developed. Next slide. So it is also important for us to follow some steps as we do our assessments. It is good to do a baseline or initial assessment. After the assessment, you should be able to debrief or provide feedback to the stakeholders that include the healthcare workers at the facility, the in-charges at the facility. It is good to give them a feedback, a positive feed. You start first from the positive one. If there is anything that needs improvement, you then follow. You should be able to develop an improvement plan. It's not just to do the assessments, but you should be able to sit together, work together for the facility management to develop an improvement plan in order to identify the gaps that have been identified during the assessments. So ongoing, or what we call formative supervision and monitoring, is very important, because if you did an assessment, let's say at the beginning of May, you want to see what progress has been made at the end of May. So that also leads to what we call reassessments intermittently according to the levels of priority, because we already talked about the levels of priority from top priority, and all of those. Some may require you looking at what has been achieved in 24 hours, in 48 hours, and in a week time. Next slide. So in the pre-assessment, we've already talked about this. It's good to have an introductory section. You introduce yourself, you introduce the team to the facility leadership so that they know why you are there. If they do know why you are there, they will honor the visit, and they will be very, very cooperative. They will participate, and they will give you all of their challenges and those things that required attention. So the assessment, we said there are several methods that can be used during the assessment. So it can be direct observation. That's why it is good to go on site. Then when you use the eye to do this, physical evidence, sometimes you want to look at record review, to look at the, if they say they have some IPC supplies, maybe you want to see where are those IPC supplies. You want to observe hygiene practices. You want to observe waste management. You want to look at the records and to look at the data over time. Maybe if they say they have this supply, when did they receive this and how they are using it. So you can also discuss, you have discussion. You do simulation. Simulation is where you create like a case. Let's say you are not seeing a particular case during the assessment in the CTC or CTU, but now you can create a case assuming that you have a patient to be admitted in the CTC. You tell me, what is the first step, what is the second step, or what are the things that should be considered? Or let's say you want to clean an environment. What do you do first? Like our colleagues were talking about cleaning and disinfection. You want to know whether people are cleaning in the right order. That is, whether they are cleaning before disinfection. You want to know whether they are demonstrating that. How do you clean the environment? Those are simulation questions. Then you also, another critical component is, after all of these, you should be able to provide some mentorship, on-site mentorship and supportive supervision. On-site, this is very important. As you do the assessment based on the gaps that you have identified, you'll be able to put the teams together and do a quick orientation for the team. With this, it can be able to improve some of the immediate gaps that have been identified in terms of knowledge and practices. So feedback to the end users and administrators is also very important. Next slide, please, Deborah. So how to use the tool. We already talked about some of these. It should be used to identify gaps where action will be capacity in terms of knowledge, capacity in terms of isolation, capacities in terms of stock management or supply management, and all of those. So the assessor should be able to develop an improvement plan for each of those indicators we talked about already. Next slide. So this is just a snapshot of the tool. It has the general information section. I know some of you may already be using some tool in your different countries in order to identify gaps and area for improvement. You want to know the date you are doing the assessment. This is very important. It will inform you when next you think you can do the next assessment, the name of the person. This one is very important because if, for example, the data are submitted to national level, maybe you want to get some clarity or clarification, then you can also contact the assessor. So you can just see the name, the contact information, email address, the facility name, the districts, the provinces, the GPA coordinates, and all of those you can see. Then one important thing is the scoring mentor with the responses. For example, you want to know whether there is a facility IPC focal pressing, if yes or no, and yes or no, we could say yes is equal to 1, no is equal to 0, so that at the end of the day, you can be able to have some specific score for each of the facility. Next slide, please. Yeah, so these are the six core areas that should be assessed: occupational health, staffing and training, and reinforcements and infrastructures and supplies, water, sanitations and hygiene. Some of the core elements were mentioned by the first presenter, the second presenters, and the third presenter: cleaning, disinfections, and laundry, and especially the practices we talk about it. You want to observe the practices, the cleaning practices is also one of the major areas that should be looked at. Next slide. So the improvement plan, we talk about it. After you have identified the gap, you need to also develop the improvement plan. That is, what are those actions that are required for you to address those gaps? Some may be immediate, short term, and some may be long term. So it is good, for example, if you're talking about construction work, some of those things can also take time. But if you're talking about maybe replenishments of supplies, or maybe you identify gaps in knowledge, some of those could be immediate. Maybe you want to do an on-site orientation based on the gap. Maybe you're talking about sharp safety. You want to talk about maybe there is poor environmental cleaning, poor application or utilizations or wearing of PPE. Some of those things can be done in the course of a day or 24 hours or on-site as you do it. But those that required maybe
So
construction.
Moses, can you quickly wind up? We are running out
Then,
of time, please.
you should assign a person. This is one of the critical areas. There should be a responsible person to identify, to address each gap that is identified, what at the facility level or even at the national level. And the resources are also very important. What are those things that are needed? Who will provide them? And you should set a timeline. And when you set the timeline, we talk about this, you should be able to follow up to be able to evaluate what were put in place. Next slide, please. So we said the implementation cycle of IPC measures in healthcare facility is continuous. It's continuous. It starts with the assessment, the improvement plan development, revision, supportive supervisions and monitoring, and you also re-evaluate to see if the plan that was put in place have been fully implemented or partially implemented. Then also is cyclical, it's continuous, as you can see. Next slide. Yeah, so this is a stepwise approach. We already talked about the planning process. As part of the planning for action, you may want to know what are those things that are needed in order for you to do, to address the gap that have been identified. Even before you do the assessment, also, you may need the assessment tool, the assessment team orientation. Then you do baseline, you develop and execute the plans, you evaluate the plan. Sustainability is very important because some of the practices you want to see whether is lasting for a longer period of time. It should not just be transient. How do we sustain the gains we've made? So this is very important. So this is just a stepwise approach. Next slide. So one of the things I was proving in other countries to be very useful, like during the Ebola viral disease outbreak, is to have a weekly activity summary or report, because you also want to have people, and it was very effective. So you want to see in terms of what, maybe at the facility level, IPC focal point that maybe you need for them to report to the districts. So during the week, like this week we were in when you started, what did you do? Okay. Who were the partners? Who were the recipients or the beneficiaries of the activity? Where was it done? Maybe now Dave will be talking about the specific CTC, the name of the CTC. Well, what did specifically did the person go there? And why was this done? The purpose of the visit, was it about training? Was it about mentorship? Was it about supervision? Was it about supplies? So then also the upcoming actions, you want to have an insight about what will be done or what this person will be doing the following week so that you can also keep eyes on them. So that is the last slide. And I say thank you very much. And I pause for your questions.
Thank you very much,
Comments.
Moses, for that presentation on the CTC assessment. Really appreciate and very good information. So quickly, due to time, I'm going to call upon Malawi to give us a presentation on their best practices and as far as IPC is concerned. After Malawi, we'll have Zambia, Madam Precious Kalugula to come through. So we start with Hamidi. Can you please go ahead and make a presentation? You can put it in presentation mode, Hamidi. Please go ahead.
Okay, are you able to see the slides?
Yes, we can see the slides.
Okay, thank you, Dr.
Just
Kapaya.
put on your camera, your video.
Okay, thank you, Dr. Kapaya. Good morning, good afternoon, colleagues. My name is Hamid Mponda. I'm presenting on behalf of Malawi team, and I'll be sharing the best practices for Malawi. And this is just a summary of what the previous speakers have presented, and we just want to translate it into now a real life situation. So, okay, so this is the outline. I'll give you background structures, coordination, SOPs, training tools, and the way forward. So on the background, cholera outbreak actually was declared on 3rd March 2022. Since then, we've had the 300 cholera treatment facilities, and they were distributed across all 29 districts in the country. So this is the distribution of cases. So you can see and appreciate that the spike of cases started from the month of December to somewhere around April on this graph. And we've recorded almost 60,000 cases with the 1,700 deaths. And this period from 1st November to date, this is our cholera season normally starts on the 1st November. So from 1st November 2023 to date, we have recorded 261 cases with the 3 deaths representing CFR of 1.2%. So this is the structure. So you can appreciate that the IPC program is available both at national level and the district level, and even in the communities. And at national level, it is housed within the Quality Management Directorate, and is being headed by the IPC focal person there. And at district level, is there within the district health management team, and actually is being headed by IPC focal persons. And even this translates to the health centers and facilities. They also have some IPC focal persons. So in terms of coordination, we have been coordinated quite a number of meetings, and actually is being chaired by QMD IPC focal persons at national level and co-chaired by WHO. And we normally had some meetings on a weekly basis. Some were virtual and some were physical. And these physical meetings mostly were occurring in the health facilities. And the participants were from different organizations, civil society organization, and even some ministry officers, both at national and the district. And normally we are sharing some best practices, strategies, guidelines, and protocols, and even sharing some experiences that they were encountering in the CTCs and CTUs. And at times we are being engaged in bi-weekly meetings with the other pillars, that's like the WASH cluster pillar, case management pillar, logistics, RCCE, vaccines, and even point of entry pillars. We are also participating in those pillars. So IPC SOPs and guidelines, of course, that in this one, we had to adapt the IPC SOPs from GTFCC, and we adapted with the different partners and the stakeholders. And during adaptation, we made sure that we include the issues to do with the waste management, PPEs, hand hygiene, human resource waste management, and even environmental cleaning. So we also had some trainings. So we had to adapt the IPC-WASH training package, which we standardized for everyone to have access so that they can use in their area of work. So we had to put this training package online where everyone was able to access it. So we managed to train 30 TOTs, training of trainers, and then these cascaded to 205 staff in various CTCs. And these 200 staff also cascaded to their fellow staff. And these one were mainly on job trainings and even mentorship. So we almost achieved close to 3,000 to 3,000 healthcare workers in those CTCs. We also had some supportive supervision and mentorship. Under this one, we managed to mentor 35 CTCs in 5 cyclone flood affected districts. As we are aware that Malawi was one of the countries which was affected by the cyclone, and we prioritized some health facilities in those affected districts. So we mentored the focal persons and actually encouraged them to use the IPC daily checklist to ensure that IPC-WASH practices are being adhered to in those CTUs and CTCs. And we even empowered the district team to implement some improvement plans, because after those assessments, after those mentorship, we end up developing the improvement plans which the district's health facilities were implementing. We also adapted some tools, integrated the tool from GTFCC. So this one we adapted together with the stakeholders and even with the IPC-WASH experts. And we had conducted the assessment in CTUs. And these assessments were conducted at 2 levels, national and districts. And even at the facility, we were also doing these assessments to assess themselves and find the gaps and develop some improvement plans. And from the initial assessment, actually it revealed some gaps actually in terms of human resource, supplies, training, and even monitoring. We also adapted the screening tool, which was deployed to health facilities and CTUs. And this screening tool was being administered by the support staff, especially the guards at the entrance, just to ensure that there will be no transmission in the OPDs or in the wards, as in some maybe cases could escape through the entrances. So we could capture those cases and do the needful right at the CTUs before they move into the wards or OPDs. So this one was being conducted in all health centers and even in those CTUs. So mainly it was just to promote the community trust and the continuity of essential health services. We also adapt this checklist This is the
Please
daily.
consider winding up.
Okay, thank you. So on this checklist, it was just to encourage the facility level find their own solutions based on the gaps that they found on daily and for some improvements plans. So also had the water quality surveillance. So under this one, we normally assess the FRC, free residual chlorine, pH, using the pool testers and even the turbidity using the turbid tubes. We also had some community scorecard, and under this one, we managed to visit almost 20 flood-affected communities. So we target the markets, police stations, and even the internet dispersed places. On that one, we identified the gaps and related the communities developed the improvement plans. So in terms of challenges, of course, the climate-induced disasters actually erased all the gains made before. So, and even the accessibility to some of the facilities were very challenging. And reporting and investigation of highs is also a problem. Inadequate IPC-WASH supplies, materials, and up to the resource for capacity building and abrupt partner exit. Recommendations, we need to develop IPC-WASH supplies quantification, forecast, and real-time monitoring tools. We also need to provide WASH infrastructures in other facilities, and even to have an investment in the IPC emergency preparedness, readiness, and response. And actually to support the national operation plan that has just been approved, because this one will actually enhance the IHR core capacities, and even to have some post-emergency stakeholder review meetings. So reaching this far, thank you, for your attention.
Thank you very much, Malawi. Thank you, Hamidi, for a very good presentation. Quickly, I'm asking on Zambia, Madam Precious Kalubula, to proceed and give us a presentation on the Zambian situation.
Thank you, Dr. Kapaya. I would request the Afro team to share my presentation.
Amarachi, can you share the presentation for Zambia?
Absolutely, let me pull it up.
We're still waiting, Amarachi.
Okay. Thank you. Good day to everyone on the call, and thank you to the Afro team for putting up this webinar today. So I'll present on behalf of the Zambia team some best practices from Zambia. The first slide is just showing us the presentation outline and some of the core components that we are using as Zambia. The other picture on the right in the middle, that is just a picture of the IPC national guidelines that we are hoping to be launched mid-June this year. We'll go to the next slide. So this slide is just showing us the updates on the epidemiological situation of cholera in Zambia. To date, Zambia has recorded more than 23,000 cases with 740 cases. And we have a 1.3 case fatality, that is health facility-based case fatality. And overall, we have the 3.2 case fatality. So there are some of the risky factors that are obvious in most of these areas where these cases are coming from. We've got old infrastructure of the water and sanitation utilities. We have low perception levels in the community, inadequate capital investment in terms of water and sanitation, which is leading to the dilapidated systems. And this is bringing the situation of people using contaminated water. And also we have a situation of high human mobility across borders. We know that our borders are quite porous, and there is no borders actually for the communities that are along the borders, because they behave as one family. So if in DRC there's cholera, then the risk is very high for cholera to be transmitted into Zambia. Next slide. So the strengths in terms of IPC-WASH program in Zambia include a three-tier IPC structure that we have starting from the central level. And we've got 3 sub-national levels, that is province, district, and also we have structures now even at the community level. You know, this has been established using lessons learned from the previous outbreaks. We also have guidelines and structure to support the O levels. We have laws and regulations to support IPC-WASH implementation in the country. We have the political will to improve IPC-WASH. As we go in the presentation, we'll see the political will actually from the office of the president, who gives a directive that all public places should have access to potable water and also hand washing facilities. The funding mechanisms are there from the government and partners. We have the presence of monitoring and evaluation systems and tools, for example, the WASHFIT, and we are also using the tools like the one that Moses was just showing us on the webinar. And also we have the human expertise at all levels. Next slide. Okay, so these are just the, this shows the status of the IPC components in Zambia. We know that the global IPC global strategy has got these components, and as Zambia, we have adapted actually to ensure that the IPC program is in accordance with the 8 core components, which will help to improve the IPC situation in the country. So we have the IPC program there. We have developed and disseminated IPC WASH guidelines. We have developed SOPs and tools. We have adapted and rolled out some of these materials and tools. We have developed the cholera multi-sectoral elimination plan, which is being implemented with the efforts to eliminate cholera. We've had the intra-action review for the cholera outbreak that is started in October, and we are still recording cases, especially in Lusaka and Kitwe. These are the 2 districts that are still recording cases up to date. We have the IPC-WASH assessments tools that we're using in the CTCs and CTUs, you know, with the support from the search team that we had. We learned a lot, and this tool has been adapted and is still being used. And adaptation of the WASHFIT with support from UNICEF. This is doing very well, and we had a meeting actually where the tool has been adapted, and the provinces, the national level is now rolling out the use of the WASHFIT. Adaptation of community assessment tools, and we've had more than 300 healthcare workers and more than 100 CBVs trained during the cholera outbreak just to support the response. Next slide. Okay, so some of the best practices that we recorded as Zambia, we can see there that there was training of the healthcare workers and community volunteers in the hotspot provinces, which included Lusaka, Central, Southern, and Copper Belt. And this was to ensure that there's knowledge and skill transfer from both the local and external expertise that we had during the cholera outbreak. The other one is we had the SAGE team. You know, when we had the SAGE team, some of the things that were not being done to, to perfection, they were perfected because we had the expertise that we needed to ensure that we improve in terms of the skills and knowledge transfer. Next slide. It's taking time for the slides to move. Okay, so this is some of the guidelines that were developed. We have now the integrated cholera guidelines, which have got all the pillars in terms of IPC, case management, RCCE. So these guidelines are being consolidated. We were using them as a draft, they were in parallel components, but now they've been put together so that we can have a comprehensive guideline, national guideline in terms of cholera to guide the future outbreaks. We also developed the community integrated cholera response strategy that has been implemented in Lusaka and Copperbelt provinces. And this is just like an expanded CATI approach that was being used actually. And we've seen that it has really worked for us in Zambia to control the cholera outbreak. Next slide. So best practices continues. We see there, following the rule of training the staff before deploying them. I think in the question and answer platform, I saw a question where people were saying there is a lot of fear amongst the healthcare workers to be deployed into the cholera centers. So for Zambia, we made sure that the healthcare workers were given prior training before they were being deployed to the cholera treatment centers and the units. And also we had PPE. We had actually a lot of PPE with support from WHO and many other partners that came on board. Functional hand hygiene facilities with supplies, chlorine, soap, water, alcohol-based hand rub. We got all these with collaboration that was going on amongst the partners and government. We had adequate beds. Sometimes when you're overwhelmed, we've seen some outbreaks previously where you manage cases from the floor, but this time around we had a lot of support in terms of ensuring that patients had beds where they were being managed from, and also IPC-WASH commodities, both at facilities and even in the community, because we're using the CAT approach. Availability of focal persons at all levels of the healthcare system, and also the buy-in from the community. This also was a best practice because, there was concerted efforts with the community and the Ministry of Health and other partners to implement the interventions. Water quality monitoring, as we can see in that picture, it was an ongoing at the CTCs to ensure that the water that was being used was really potable and safe and clean water in the CTCs. There was high levels of awareness among healthcare workers of injection practices. There was continuous on-site mentorship and training in the CTCs, because in some instances there was some attrition, of staff. So there was that continuous skill and the knowledge transfer to the facilities. Next slide. Yeah, so there was intensified community engagement and risk assessment, and we see there those pictures, this is what we're finding, and we're actually using the communities to go and do risk assessment as we were following up on the cases, because the approach we're using for each case, we were ensuring that households within the 50-meter radius visited and, given a comprehensive package of IEC and training on how to treat their water, giving them domestic chlorine to ensure that their water is treated. And those are some of the findings that were being discovered as, you know, communities were being okay, so we can move on to the next slide. So despite all these best practices and achievements that were made, the gaps were still there and challenges. So not fully established national health associated infection surveillance system. You know, we do not have adequate data that we can use to plan actually on how to, what is the intensity of healthcare associated infections in our CTCs during the cholera outbreak. This information is not there. There's only sporadic information because whereas in some instances where we lost healthcare workers due to cholera, but not really a system that was there, you know, established to collect this information. So this is one area where we are lacking. Some CTCs and CTUs designs did not support the implementation of IPC and IPC practices. This was really a challenge in some of the areas where cholera cases were recorded. Dilapidated and broken down sewer and water reticulation systems. This is still a challenge because these are capital, you know, investment. They require capital investment from the stakeholders, and you find that not so much is being put into this area to ensure that the infrastructure for water and sanitation are improved. And we see that this is something that might, you know, make us continue having these outbreaks despite, you know, making the, you know, controlling cholera adequately and successfully, but still, as long as the water and sanitation infrastructure remains the way it is, we'll still have challenges to eliminate cholera. So there was some practices of spraying chlorine at high pressure in CTCs, and it was quite rampant, and it is something that we are dealing with. It is something to do with behavior change, and as well as for people to understand what the effects are and why it is being discouraged using the guidelines that we have provided. And non-harmonization of guidelines from the different players. You know, this time around, we are seeing that early detection, some guidelines from other partners say that detection should be within 7 days, detection and you know, investigation should be within 7 days. Meanwhile, the other guidelines are saying that detection and investigation should be within 24 to 48 hours. So you see that kind of non-harmonized guidelines puts, you know, the practice at difficult, because this player comes in with this guideline and another one. So there's just confusion. So there is need to ensure that these guidelines are harmonized by all players in the cholera preparation and response. We have inadequate documentation of cholera prevention, readiness, and response actions, you know, and I'm happy to see that now these tools can be rolled out. I think it will really help to document the lessons learned so that they can be used for planning and prepare for future outbreaks. Inadequate hand hygiene practice compliance in both community and healthcare workers. You know, sometimes the facilities are not adequate.
Quickly wind up time. Thank you.
Yeah, I'm winding up. And also inadequate coordination. I think this is one thing that we saw, that sometimes there was not good collaboration amongst the stakeholders. I think the slides will be shared. I think people will be able to read the detail. I think this is my last slide. Okay. Okay, the next steps, I think, is just to improve collaboration and coordination with the many players, adapt IPC training curriculum. We are happy that the global level has given us the in-service training curriculum. We are already in discussion with the government on how we are going to advocate for this curriculum to be included in the healthy training institutions curricula, and also to improve on signages, IPC signage, even just in the healthcare facilities, not really in CTCs, you find that there is little signage to show what is required in terms of IPC. WASH, human resource in hotspot districts, I think this is an area that needs to be improved. Rolling out WASH feeds, this is another next step that we are working on, and also to develop and roll out routine cholera IPC-WASH assessment tools. I think we already have tools that we are going to adapt, and to establish a water quality surveillance system that is going to be routine and just to expand when there's an outbreak. Also to improve technical and supportive supervision, and to improve on documentation of all the actions that we undertake during the outbreak. Thank you. I submit.
Thank you very much, Zambia. Thank you, Madam Kalugula, for that very good presentation. We now go to discussions. I'll hand over to Dr. John Masina to help moderate the discussion. Dr. Masina.
Thank you so much, Dr. Kapaya. I hope everyone is able to hear me. Good morning and good afternoon, depending on where you are joining us from. Thank you so much for the presentations. I think we've had 3 presentations from the last time we had the discussion. We had a discussion from Moses on the 2 assessments, and then we have a discussion. We had a presentation from Hamad on best practices from Malawi, and I think top of the highlights is the adaptation of training packages, the cascading of the trainings, and also the supportive supervisions that were conducted throughout the response, and also the adaptation of screening tools, which I think Moses has alluded to vividly. And then lastly, we had, I think, the last presentation from Zambia, which also talks about the adaptation of the IPC core components, and also the rolling out of training materials, and also training of healthcare workers. And I was very happy to see the question on mitigation of fear in healthcare workers being handled from the Zambian team, which I think was also a very good practice in that aspect. So I think I'll open up the floor for live questions. I've seen some questions have been answered in the chats, and a lot of questions are still pending. I think there's a question in the chat as well. But if there are any questions that we can have on the live discussions, please just raise up your hand, and then we can discuss. Any questions? And also the presenters and the panelists, please just look out for any interesting questions on the chat that we can pick up and answer in the live questions. So any questions from the 3 presentation, or any additions from the other presenters as well? Over to you.
Good afternoon.
Yes, please go ahead, Innocent. Good afternoon.
Yes, indeed. These have been very educative presentations across from the WHO Afro region, and also sharing experiences from the countries from Malawi and Zambia. Our call is to make a request for more support. As you can see that the IPC is evolving, and we have got now also the curriculum for postgraduate, and also would want also to enhance it so that we can domesticate it and identify one of the university where we can also pilot such things. So in the background, we are also having an engagement how we can roll out this curriculum to the universities. So it requires a lot of support, both from internally and external. So support so that we can also reach out to that. Secondary is also a global strategy. We are looking forward how we can also be supported in terms of the healthcare associated infections surveillance system. As you can see, during the GIE, we didn't score well. We had 1 out of 5, and that is an area where we can also improve. Definitely, as Zambia, have got a milestone where we have a 10-year plan, action plan for AMR, but we need more support because at 20%, which means we are not doing well. So it calls for both external and also internal support in terms of both technical and also financial support. I submit. Thank you.
Thank you so much, Innocent. Institutionalization of some of these best practices is the best way to go. I think it also brings sustainability and it also brings ownership into the programs. And I think most of the players in these areas are getting these requests and being tabled at higher levels as well. It's a well-valid submission, and I think there will be a lot of discussions around that, and it's the only way for ownership and sustainability. Thank you so much for that submission, Innocent. There's I think maybe it's a comment. Oh, it has been deleted in there, or is it someone else has answered it? I think there was an issue on the decision making, and also an issue on the training aspects, and also an issue on supervision. I think it was was it Hassan? I'm not sure. There was a comment on the chat. I think I've just lost it. But I think someone else has answered it. Thank you so much, Innocent, for that submission. Any other questions or any contributions from the other presenters?
Yes, yes, John, this is Moses.
Sure,
yeah,
you can go
so
ahead.
regarding Hassan's questions, I already responded, but just to provide an additional comment, at times training alone is not sufficient. So if you have provided trainings to healthcare workers and they are not applying the standard case definition, you may want to go further. What are those things that are also affecting their practices? Is it maybe like ideally cohorting patients is ideal, but what if the facility itself is not in a way that accommodates such? So you may see that, or maybe the issues of supply. So there are a lot of variables that you have to look at. So instead of just the training alone, training alone is not sufficient to affect behavioral change. There are other factors that affect the applications of knowledge. Thank you, then over. Mr. Soro, you want to add up something?
Yes, sure. Sorry, you can come through.
Okay, thank you so much, Moses. Yes, I think you already answered the question. So, IPC's mentorship also is very important to change things, because implementation of the procedures is behavior change. So we focus on the culture, change the culture of healthcare workers on that. But I also want to comment on what Innocent just said regarding the IPC global strategy. But yesterday I have the chance to meet your IPC focal person. Somebody spoke on behalf of Zambia here during the World Health Assembly here in Geneva. So that was something that Zambia really highlighted regarding the implementation of the global strategy on IPC, and we appreciate it. And I think the team here has been in touch with them, and then we'll be happy to support you in that initiative. So secondly, to Precious, thank you so much for the nice submission. I appreciate it. So I just want the clarity on the IPC national guidelines. I know you talk about it, but I did not get it well. You mean the guideline has been already finalized and to be validated, but maybe some clarification on the national IPC guideline that we've been talking about it. Thank you so much, and over.
Okay, the national IPC guidelines together with the strategic plan, they are being validated actually right now. We are having a meeting where we are validating. Thank you.
All right, thank you so much, Precious, and thank you so much, Soro, for bringing up that. Also, thanks, Moses, for clarifying. And I fully 100% agree with you. Training is really sometimes it's not enough, but most of the time we also encourage to do spot check analysis. You can also do training impact evaluations from time to time, just to see and also just to bring in the aspects of drills and simulation exercises, so that you can test the system and see how best well the system is adapting to the change and what's going on. So really, training is actually the first step, and then you can go on to evaluate and see what the impact and what could be changed going forward. So there are a lot of multifaceted spaces to look at in terms of improving. And I think one of the slides in your presentation also highlighted the need for continuous assessment values, and also to group the immediate to intermediate and long-term fixing problems as you go. And I think it's important to also see how regular you do these assessments and how spot check these assessments can be, so that you can improve in terms of quality improvement and quality assurance. So these are really very pertinent discussions and very important discussions that we are having. But in the interest of time, thank you so much, everyone, for participating, and thank you so much, everyone, for the good discussions that we are having. I just want to hand over the moderation to Christopher for the next steps, and then we can wrap it up. Thanks, and over to you, Christopher.
Thank you, John. So just on a small wrap up, we've seen a lot of interesting presentations since the morning on different WASH and IPC response, preparedness, readiness, interventions, what needs to be done in advance, including the use of specific tools or methods. And we've seen also a lot of we've heard some contribution from colleagues in countries, in Malawi and Zambia. So all this were highly appreciated, and I want to thank all the colleagues that have presented. So on next steps, in a way, I don't know if I can call it next steps, but the thing is, WASH and IPC are closely interlinked, and of course the two actors, the two sectors should work closely together, with keeping in mind that the highest concentration of the risk remains in the cholera treatment facilities. So with a focus priority on this, that we saw that we briefly mentioned that interruption of transmission around cases is key if we want to limit secondary transmission and limit also the people that will come to the CTC then. However, we didn't get really into the details of the CATI and cluster targeted intervention approach and so on, but it's very difficult because it needs quick intervention in the 24-48 hours. So it needs a very high level of preparation. Also, it needs to be guided by epidemiology, so which means a good cooperation between the health actors and the WASH actors. And also, when we're doing this, we're only addressing the tip of the iceberg, because we're only seeing symptomatic cases, and we know that maybe 70 or 80% of cholera cases could be asymptomatic and continue to fuel the spread of the outbreak. So this is why we need to work during the emergency response on quick emergency WASH preventive activities at community level, but also we need a high level of advocacy towards long-term WASH investment in cholera hotspots. Maybe key messages or recommendation to take out from this, I would say cholera regularly affected countries are highly encouraged to engage in cholera preparedness and readiness, as it's key for an effective early response, and an early response is key to control and to avoid to have a huge peak. To do this, we discussed in different presentation the importance of coordination, coordination structures in advance of a cholera outbreak, not only when the cholera outbreak hits, with a strong IPC and WASH readiness component, and trying to involve all the relevant health and WASH actors. So health and WASH actors often don't talk to each other in day-to-day life, because some are engineers and they work in water facilities or in a different ministry, and some are working in health facilities and or in the Ministry of Health, and there is no natural connection. So this all the thematic of cholera is a good opportunity to bring all these colleagues together. Maybe I would encourage also countries to request support to WHO, to UNICEF, to the Red Cross, and to all the GTFCC partners that are present in country, to support with training the rapid response team, to support with guidance, with SOPs, with tools, both in the health and WASH sector, as all these materials have been developed and are already existing. So, of course, they can be adapted and so, but it's easier to start with the basis, and with a basis that has gone through a long revision process. And so I would say don't hesitate to reach out to the GTFCC community, even at country level, so that you can benefit from all the support and the tools that are existing already. I would encourage also to identify proper triggers for WASH IPC readiness and early response. For early response, it's quite clear, but for readiness, we can think of different triggers. It can be cases, as I was mentioning before, in neighboring countries or neighboring districts, but it can also be that we know that there is a kind of cholera seasonality, for example. So if outbreaks regularly start in June, maybe by May we should be ready and have all the teams trained and have all the material prepositioned. So all this maybe needs to be defined at country level, because from a country to another will change, but also could be defined at region or district level. And I kind of insist, because our presentation was quite technical, but the fuel of all this response is the funds, the funding. So it's really important, even if you manage only to have a small amount of money, a small pot of money, but to have a contingency fund ready, so that it can fund the readiness activities and it can fund the early response activities. Then, while cases are being reported, you can call for emergency funding. However, we can say anticipatory action funds are super needed if we want to be on time. Most of the time, we haven't looked at a timeline here, but most of the time our response, even if it's good, finally it's too late to have a huge impact on the response and to be able to control it from the start. So if we want to be able to do this, we need to be prepared, and to be prepared we need a bit of money. Over to you, everyone.
So thank you very much, Christophe, and all the participants. Thank you for this wonderful webinar, and we'll be able to share the materials with you, all of you, and you were asking about this. But just to say thank you and wish you well. We've come to the end of our webinar today. Thank you very much.
Thank you so much. Have a great